Welcome to the February 2024 edition of the European Urology Podcast. My name is Declan Murphy, urologist here in Melbourne, and I'll be joined shortly by my co-host, Joyce Baard, urologist in Amsterdam. The February 2024 edition of the journal is an absolute cracker, jam full of some great papers. As ever, we don't have time to go through every paper here on the podcast, but we have selected two papers which we hope you will really enjoy, two quite different papers. The first is focusing on AI in urology, a very hot topic. Joyce will be joined by lead author Giovanni Cacciamani from USC, who put together a great collaboration of experts from around the world. And they'll also be joined by Annabelle Odishu, a urologist at UCSF, who's had a long-standing interest in all things AI. I remember we had a great chat with Annabelle just when ChatGPT launched on GUcast, one of our most popular episodes back in 2022. Our next paper is a bladder cancer paper. It's focusing on the very important topic of adjuvant therapy after cystectomy for muscle-invasive bladder cancer. We know the recurrence rates are way too high for this population, but what are the adjuvant treatment options? Well, we're going to present an overview of the biomarker analysis from the IMvigor010 trial. And first author in that trial, Tom Powles, medical oncologist from Baard in London, will be here to tell us all about it. I'll be joined for that discussion by Associate Editor at European Urology, Dr. Laura Bucavina, who's a urologist at Case Western Reserve University in Cleveland. Laura will also stay on for a chat with myself and Joyce after that segment. We like to chat to our new associate editors on European Urology, so you, our audience, get to learn a little bit about what it is they look for in a paper in European Urology. We'll learn a bit more about Laura, how she got to do what she does, why she loves what she does, and what else she does outside of urology. And finally, Fabian Stangl is a senior urology trainee. He's a fellow in Bern in Switzerland, and he's going to cover our what else catches our eye in the journal this month. He's picked out 2 or 3 papers to whet your appetite. All of the links will be in the show notes below, but let's kick off by going to Joyce and her discussion about AI in urology.
So we will start today with a very interesting topic. We're going to talk about AI. And I'm very happy to introduce our first 2 guests. Our first guest is the senior author of the paper we have selected for today. It's on awareness and use of ChatGPT and large language models. This is data from a prospective cross-sectional global survey in urology. And the senior author of this paper is Dr. Giovanni Cacciamani. He's associate professor at the University of Southern California, Los Angeles, and he's also the chair of the Young Academy Urologist in Urotechnology and Digital Health. So, Giovanni, thank you so much for making yourself available to be here today. Congratulations on your really nice and interesting paper, and great that you're here today.
Thank you so much, Joyce. Thank you so much, Declan, for having me here. I just want to mention that, this paper is the result of a hard work of an entire team, which I'm, proud and happy to be part of, which is the Young Academic Urologist Working Group of Urotechnology and Digital Healthcare. And, again, thank you so much for the invitation, for providing you guys some of the latest insights about this paper.
Great. And we have invited a second guest who is a well-known expert also on this subject. And maybe you have seen him on one of the episodes of GUcast of last year. A really nice episode. And I'm happy to introduce Annabelle Odishu. He is an associate professor of the University of California in San Francisco. So welcome and thank you for being here today to discuss the paper with Giovanni.
Thank you for having me. Looking forward to it.
So before we give you the words to discuss the paper with Giovanni, maybe you could start with a brief introduction of your paper, a little bit about the background and also the key findings of your study.
Yes, absolutely. So it was basically November 2022 when ChatGPT, come into the spotlight. And I remember one of my residents that came to my office say, "Hey, did you hear about ChatGPT?" And at that time, I would say, "No." I mean, initially I thought it was like a dating app, like whatever. So and say, "Okay, tell me, explain to me." And we have our residents joining, some of our research fellow. And what we figured out is that in that moment, we feel that something changed. I'm not kidding. I mean, I'm Italian. You know how much I care of coffee and good pizza. So we literally stay in my office until 2 a.m. with Domino's pizza, which, all of you can understand that is not real pizza at all. But to make you the point that how much we were interested in this thing, testing this new technology. And it was kind of mind-blowing. So at the very beginning, we start saying, okay, I'm pretty sure that some other urologists all over the world will start, having some interest in this. And, 1 month later, we established a group in Twitter, which now count almost 1,300, members, EuroGP tweet. We tested and we touched the interest of the urological community around this thing. I mean, urology has been always in pole position in embracing new technologies, lasers, robotic surgery, the imaging technology, pathology. So again, AI is not an exception, and it's very clear that AI will have been started being something that the urological world will have started, begin using. So, for that reason, we, the team, together with the Young Academic Urologists Working Group of Urotechnology Social Media, and together with the European Society of Urotechnology, some representative, we, design this survey. And before sending out the survey, we uploaded the survey into a server. So, technically speaking, methodologically speaking, this is very important because if you can see in advance which are going to be the aim of the study and the questions, you're going to be sure that the results are going to be based on the questions that are uploaded in advance and not something that you're going to change during the process. That was the first thing. The second thing is that we sent out the survey over a period of 2 months. And what we figured out is that we have 500 urologists all over the world that decided to take their time to reply to this survey. Why is a prospective global survey? Global, of course, because we try basically to make global as much as possible. And we try to reach out as much urologists as possible all over the world. Prospective, because this is just the first of 3 steps that we are planning to do. The first step is, of course, testing the awareness about ChatGPT, generative AI, large language models within the urological community in terms of how this technology can be used from clinical setting and academic settings. But then we are planning to do the same survey and to submit the same survey to the same people at 12 months and 2 years to understand basically if the usage of this technology will change over time. So, our main findings were that, I invite all of you to read the full paper in European Urology, that the majority of the responders were aware about the ChatGPT. The majority were using it, but very few are using it now, at least at the time of the submission of the survey, for clinical purposes. And this is very important because, there are several concerns regarding the 6 pillars of the ethical use of AI, which actually has also been reported by the WHO in 2021. And one of these is cybersecurity. So we don't know where those information could potentially go, especially clinical information. Regarding research and regarding academics, this kind of technology can be the perfect ally for improving your academic and research skills. But again, everything has to be done with ethics. Padre Paolo Benanti is an engineer in Italy. He's the advisor of Pope Francis. In 2020, he coined the term algorithmics, is a mix between two different terms, algorithm and ethics. And these things has to be taken into account every time when we are testing or evaluating the performance of an AI tool within clinical and academic settings. And again, first, so the first thing I can say is that first, it was stunning to see how much the urological community wanted to contribute and give their own insights regarding the use of this technology. And secondly, I'm proud to say that we are the very first one that actually are releasing a survey among physicians. And now there are 7 medical specialties that are now in the process of validating our findings using the same question, changing, of course, urology with neurology, general surgery, whatever, to see if the same finding that we have in the urological world can be applied also to the other medical specialties.
Great. So, Annabelle, what are your thoughts on this paper? And any questions to Giovanni?
Yeah, absolutely. Gio, thank you for putting out this great survey on a topic that everyone has either been hearing about or using. I think the results were really enlightening, gave us a good baseline as to how generally younger, more digitally connected urologists are experimenting with large language models. I'm happy to hear that you guys are planning on a follow-up survey in 12 and 24 months, because the space is just changing so rapidly. My sense is if you repeat it today, you're going to have very different results, particularly as these foundation models, they move from just being a standalone website that you have to log into and use separately to then having these capabilities integrated into the software that we're using on a day-to-day basis. Many of our emails, Outlook or Google or whatever it may be, these tools are being integrated into that, and it's just coming into every piece of technology that we're using. There is bias with all surveys. I do worry a little bit about sampling bias, where the participants self-selected and they were exposed to the survey either on social media or via forwarded emails instead of some sampling approach. And I combine that with my theory that I think there are 2 camps of people. One group that used GPT, did some fun things with it, experimented, came up with a couple of use cases, and then actually just basically went back to their usual workflow, and it didn't become part of their routine work. And I think maybe another subset of folks who are totally blown away and continue to use it on a regular basis. And so I'm wondering if the combination of those 2 things actually, combination of the response rates, maybe leads to a little bit of an overestimation of continued use. I think in the paper, you guys did a really fantastic job of highlighting some of these challenges with surveys in the discussion. What are your thoughts?
Well, Annabelle, this is an excellent point. And unfortunately, this is one of the limitations of basically the majority of the surveys. To evaluate basically the performance of a survey, you have 2 different tools, or evaluating the rate of respondents according to who you selected for being, the population that you're testing, or when you're basically sending out the survey, you can calculate in advance the standard error and the confidence of, the number of people that you are expecting to be the respondents for the particular field. This is actually a problem also for global surveys or for a global level consensus. Yet, once, and this is reported in literature, once you reach out a critical mass of people that are applying to the survey, chances that this particular, the finding of the survey is going to change are very minimal. Yet, I understand and I agree with you that we could potentially have a selection bias, a natural selection bias. I would say a natural evolution, like the giraffe with the long and the short neck. We use the digital tools for spreading the survey, and these could potentially be the same people that are using the most this kind of technology. But on the other side, we are very happy that even though probably we selected the people that are more digital or technological, we figured it out the majority of these people are expressing concerns on the use of this technology. So not necessarily the people that are digital freak like me actually could potentially be in favor of this technology. Technically, what we found is that 70% of the people that took a survey reported that they are very concerned about the use of this technology. And this actually is making a point. Even though people like me that are techno freak actually are going to be concerned about this thing, and therefore clear regulation are needed.
Given the concerns with patient data, I'm surprised in the survey how many people reported using it for clinical care. Given the limited number of use cases in which you shouldn't use true patient data, and then also the clunkiness of working with multiple interfaces. You have your EHR, then you have separate GPT and typing in one and copying over to the other. What are your thoughts? I saw in the paper about 50% said patient education, 20% said they used it for diagnosis, 20% in the EMR, 25% for follow-up care. What's your response to that?
Well, that is one point that actually surprised me a lot. I mean, I was kind of concerned also because, again, this technology is not HIPAA compliant, and therefore you cannot upload patient information. But if you're going to cover the important patient information, you can technically, get some output that you can use, for example, for patient education. Let me give you an example. And this happened to me also very recently. My fiancée, she was diagnosed with cancer, with leukemia. And I figured it out myself, helping her in reading the discharge disposition letter after her first chemo. I'm a doctor. Okay, we are doctors, but still we are very focused on our urological field. And when we have to read a discharge disposition letter from another medical specialty, is super difficult. And again, I'm a doctor, so I start figuring out how, if it's difficult for me, imagine how difficult it could be for somebody who's not a doctor or somebody who's not in our field. So, in terms of patient education, our team has put together a three-phasic large language model framework to extract all the important information from a letter of discharge and making this letter of discharge with a summary that can be understandable, readable first, and therefore probably understandable also from patients, from their caregiver, and from their beloved one. And I really believe that, again, this kind of technology has to be seen like a copilot. Okay, so you are generating something that has always to be overseen and validated by us. We are doctors. We see the patient in an holistic way, right? So this is just an example. And for example, you can use it for creating patient information material. Patient information material from AUA, EAU are good, but again, are very time consuming for making first. And secondly, because the time that you're using and spending for creating one, at the end of the day, is going to be difficult to update it on a yearly basis. On the other side, guidelines are updated on a yearly basis. So this kind of technology can actually be used also for extracting information from the guidelines and making them readable and understandable from patients. So I really believe that this technology is stunning. However, we have always to be one step ahead and watching it and validating the findings. At the end, as I used to say, AI will never replace us. But those of us who will take advantage of it will replace who don't.
Yeah, I think we could talk about this for the whole podcast. But unfortunately, we're a bit limited in time. I think there's still so much to explore and so much to learn. And I really appreciate that you both took the time to be here today and give us some insights about how urologists use these ChatGPTs and these large language models. So thank you so much both for your time to be here. And I'm sure we will hear more of you. Thank you.
Thank you so much.
Well, thank you to Joyce, Gio and Annabelle for that fantastic overview. This is such a fast-moving area, and here at European Urology, we are very interested in what AI means for us clinicians, for our patients, for researchers, and you will undoubtedly be hearing more about this as the months and years go by in this podcast. Next up, let's talk bladder cancer. I caught up with Tom Powles and Laura Bukovina to talk about this very nice paper focusing on the IMvigor 010 trial. So for our second paper this month, I'm delighted to be joined by one of our associate editors, Laura Bukovina, Dr. Laura Bukovina. Welcome, Laura. Laura is a urologist at Case Western in Cleveland, an assistant professor there, and her main area of interest is bladder cancer. And the reason we've asked Laura to come on is because our other featured paper this month is a very, very interesting bladder cancer paper. It is from the phase 3 mVigor-010 trial, which is for patients with muscle-invasive bladder cancer. This was a randomized trial comparing adjuvant therapy, adjuvant atezolizumab, versus just observation, which has remained our standard of care in recent years. And so to discuss that paper, we're joined by Dr. Tom Powles, a GU medical oncologist at Baard's Cancer Institute in London, who led the ctDNA component of the paper, which is what we want to talk about today. And Tom is very well known in the bladder cancer world, but also very well known to those of us who like podcasts, because himself and his mate, Brian Rinnie, run a really, really good podcast called Euromigos. So if you enjoy podcasts...
It's not as good as your podcast.
If you enjoy really good podcasts like GU Cast and European Urology Podcast...
GU Cast is the real deal. It's the real deal.
Terrific. So Tom and Laura, thanks very much for joining us and giving up your time. The purpose of this is really just to highlight some of the key elements of this paper, not to dive into it in whole detail. We've got the link in the show notes, and we really encourage people to dive into this really interesting paper. But Tom, first of all, if you wouldn't mind, though, give us a brief high-level overview of the mVigor-010 trial and what this paper in European Urology is all about.
So we know that a group of patients relapse after being thought to have been cured with surgery, with or without neoadjuvant chemotherapy. It's about 40% of patients who relapse, maybe more. And we also have recently discovered that we can identify minimal residual disease, which basically through ctDNA, we can identify circulating cancer cells. Using a personalized approach, we can identify cancer cells related to the primary bladder tumor in about 40% of patients after their cystectomy. And about 95% of patients who we can identify that circulating tumor DNA, that molecular residual disease, they go on and relapse. And so essentially, by the way, we also know if you're CTA negative, your relapse rate is much lower. In this paper, it's about 25%. In other papers, it's lower. So we've got a discriminatory test that can identify a group of patients which are going to relapse. It's kind of not validated yet, and there's a trial going on, which I'm going to talk about in a second, which is doing that. But I think it's also important that in this particular paper, we gave adjuvant atezolizumab or best supportive care to those 40% of patients who were ctDNA positive post-cystectomy. And we showed that atezolizumab, as opposed to best supportive care, was associated with a 40% reduction in the risk of death in that group. And so essentially I now identify a group of patients who are at high risk of relapse, and it appears that early intervention with immune checkpoint inhibition is associated with improved survival in these patients.
Amazing. So there's nothing we hate more, Laura, than looking at these poor patients post-cystectomy. They might have got through the big procedure, but we know, especially with high-risk features, so many of them will get a recurrence. I'm going to hand over to you to give your thoughts on this and to bring Tom through some discussion.
Yeah, I think, Tom, a great study, particularly using biomarkers in the adjuvant setting. I think a lot of us in the GU setting are way behind our GI folks. So, with colon cancer, this has been used widely for years and already has been used in the more of the approach in terms of adjuvant setting, but also more of a dynamic clinical trial and therapy in the adjuvant setting. So great big first step in knowing for our patients who need adjuvant therapy, clearly understanding who doesn't need it, particular patients with ctDNA who can be an observation. My question for you is that if you're using the targeted patient-centered approach with the 16 biomarkers, do you think that in terms of your sensitivity of detection, it was a bit lower than what I expected out of these tests? So you talk about in your patient cohort, 57% of patients had positive ctDNA, but many of them, 43% had residual disease that showed up radiographically later on. So we're missing a lot of patients who had negative ctDNA, however, within a couple of months have positive radiological recurrence. So my question is that, is it a good test? With 16 markers, particularly in metastatic disease that's based on tumor, should we be thinking more of application of both tumor-targeted approach as well as potentially a wide sort of catch catch of multiple mutations down the line, which is what some of the studies, at least in esophageal cancer, are doing?
So I think it's a great question. So if a patient is ctDNA positive, and essentially the methodology is you do whole exome sequencing on the primary tumor, you identify the mutations, and then you can track up to 16 mutations. And if you've got 2 or more mutations that are positive, you're defined as being ctDNA positive. If you've got 1 or 0, you're defined as being negative. And that's because it's possible that there is some false positivity associated with one CT alteration via chip and other methods. So I think the answer to your question is, if you're positive, your chances of relapsing is really, really high. It's about 95%. But if you're ctDNA negative, you've still got about a 20 or 30% chance of relapsing in our work. The work from the Danish group using the same methodology was lower than that. And on top of that, we're going to be presenting some data at the EAU with a different cohort, which I think is going to clarify this issue. And I think it's going to show that our sensitivities and specificity is even potentially even better. And I'm looking forward to presenting that data. The other piece, which I think is really, in my opinion, exciting, is we're doing a study called InVigor11. And in that trial, it's a prospective randomized study where those patients who are positive are included, and they're randomized immediately to atezolizumab or placebo. But those patients who are negative are also included. And we're tracking those patients. And if they become positive but remain radiologically negative, in those patients, we're also going to randomize them. We are randomizing those patients. And so it's not going to just be a study where you have to be positive post-cystectomy. It's you can become positive. Because one of the things we've learned from some of the other cohorts is there is a group of patients who are negative who subsequently become positive, maybe 20%. And I hope that will broaden our net and address some of the issues you've discussed. I think the last part to that, which is relevant, is that there is a way of looking at this very differently. At the moment, we look at cancer as if it's radiological visible, it's advanced disease. And if it's not radiological visible, it's kind of in this adjuvant cured setting. And that's probably an oversimplification. The way I think we should be looking at this in the future, post-cystectomy, is, symptomatic. Those are the advanced patients, and they have a scan. There's also the radiologically positive, asymptomatic patients. Those are the patients we pick up with CT imaging post-operatively. And then we should also define advanced disease, in my opinion, as radiological negative, ctDNA positive. And that potentially will transform the way we see the disease, because it's possible that giving drug combinations like EV Pembro in ctDNA positive patients may actually cure a lot more than 30% of the patients that we're currently seeing in advanced disease in the frontline setting with radiological visible disease. So I think if we really focus on the neoadjuvant approach, curing as many as we can with cystectomy, radiotherapy, or surveillance, and then post-cystectomy, we focus on hitting ctDNA positive patients really hard, potentially or definitely sparing those ctDNA negative patients, providing we're comfortable with the sensitivity which you talk about, which I think we can be by improving our technique, but also by following the patients. I think we can transform the definition of this disease and improve outcomes.
So Tom, the other question I had when I was reading this paper is really the difference in mutations that we know happens between the tumor, which is what you used for your essay. And we know that there's completely potential genetic mutations down the line when patients present with metastatic disease and recurrences. Do you think it's a disadvantage using the 16 gene from the original tumor, knowing the heterogeneity and the clonal changes down the line with metastatic disease, and applying that assay when we know potentially if the only 2 are positive, but those are not the 2 that perhaps the mutation, the actual metastases has? That assay is missing the patients who have a completely different clonal abnormality. And should we be biopsying those patients who recurred to compare them to the original tissue to understand if that's happening?
So the informed approach that we're talking about has a lot of advantages. And the biggest advantage is the depth of sequencing that you can do regarding that, because you kind of know what you're looking for. And because you know what you're looking for, it's easier to do very deep sequencing to see whether or not those mutations, up to 16 of those mutations, are visible or identifiable. And Natera is an example of that, for example, and that's the method we used. An uninformed approach, one of them is Guardant, but there are others, Foundation and other approaches, where you pick a series of common mutations that you're comfortable with that are often occurring in cancer. Sometimes, Guardant 360, Chad chose 360, but they've changed that and they can now identify more mutations. The issue with that approach is the selection of those mutations is really important, and they haven't historically focused on urothelial cancer. And you predefine what those mutations are. So you're going to end up missing a lot of patients. And then on top of that, historically, there have been some false positives because of CHIP and other potential reasons why patients may be false positive. And so the informed approach today, I think, is better for identification of MRD. But the problem that you've defined accurately is that if your tumor has had 3 lines of different chemotherapies and has completely mutated and changed, how helpful is that informed approach going to be down the line when actually you've developed a whole series of different mutations? And I think that the answer to that is that it may be that this panel-based approach may be more useful when the tissue you feel is going to be less accurate. And the panel-based approach is also going to be useful particularly when you're looking for specific targetable mutations and you're looking for clonal evolution and clonal changes, particularly as our net becomes wider. So if you said to me right now, if we wanted a 3rd-line patient, we didn't want to do a biopsy and we wanted to look for FGF mutations, clearly in the plasma, clearly the best way of doing that would be using an uninformed approach, and we've got a good chance of finding that. But the problem with the uninformed approach is I think you lose a lot of these, you're going to end up missing a lot of these MRD patients. Although in bladder cancer, we haven't seen enough of that data yet. And again, I think there's going to be some data on the uninformed approach over the next 6 months, which is going to clarify this issue, and it will determine whether or not my hypothesis is correct. So in the end, the informed approach, good for MRD, really deep sequencing, and good at the time of surgery to identify whether there's MRD, where the panel-based approach, probably better for tracking biomarkers for dynamic changes and probably better for personalized therapy.
Fantastic. Well, that's all we've got time for, unfortunately, but what a great discussion. What a great topic. I know for many listeners and viewers out there who look after bladder cancer patients like you and I, Laura, 2 things I get concerned about. One is giving very powerful toxic drugs in the adjuvant setting where a bunch of patients will not benefit. It remains a concern. There's a cost concern. There's a quality of life concern. So I think this piece of work where we can say we are going to be able to better identify those of you who are much more likely to get a really meaningful benefit from these strong drugs, we're entering that era. And I think that's what this paper is about. That's why it's in European Urology. And Tom, we're very grateful to you for sending it in to us, and congratulations to you for this work and for all your ongoing work in the area.
Thank you both for inviting me. I'm really grateful.
Thanks, Tom.
So, Laura, that was a great chat with Tom. And I know, of course, bladder cancer is a big area of interest of yours. But thanks for staying on the podcast, because myself and Joyce do like to occasionally have a chat with one of our associate editors, or we'll have consulting editors on, because our listeners and viewers are a little bit interested in finding out about the people who are behind the journal and about how the journal works. So thanks for staying on to have a chat about that today. Joyce, do you want to kick off and ask Laura a little bit about herself?
Yeah, so I think it's always nice for listeners to know a little bit more about the editors of the European Urology Journal. So could you maybe give us some insights? How did you become a urologist? What was your motivation? What is your field of expertise? Could you share that with us?
Sure. Thank you, Joyce. Thank you, Declan, for having me. It's nice to connect to all of our readers and reviewers and everyone for European urology. So I'm an open book. I'm a urologic oncologist at Case Western. Graduated fellowship a couple years ago from Fox Chase in Philadelphia. Bladder is my organ of love. It is both my enjoyment and my terrible days. Particularly, my favorite surgery is a cystectomy. My worst surgery is post-radiation cystectomy. So let's leave it at that. How I came to urology, I'm actually, surprisingly, was actually going to be a dermatologist. But I changed my mind a month before I was supposed to be a dermatologist. And I said, no, I'm going to go into surgery. So I ended up going to surgery, and I really loved oncology, surgical oncology. And then I came across urologic oncology, and I loved the people that I worked with, and ended up in urology, always knowing that I wanted to do urologic oncology. Sort of a very looped around, lots of pivoting, lots of sort of changing my mind kind of way. Very happy I didn't go into dermatology. Nothing against dermatologists, but it would be awfully boring for me.
Totally different field, yes.
Yes.
And you have done really a lot of research. You're an expert in the field of bladder cancer. How did you manage to do that besides your work as a urologist?
So I was always interested in research, even in medical school. So I started doing my Master's of Public Health in Statistics and Bioinformatics back then. And then when I got into residency and I started doing residency and got involved in a lot of the bladder cancer projects, and then started working in the lab during our dedicated research time, that's when the world of sort of basic science opened up to me. And I have been involved in translational basic science research since then, working with Philip Bosch on some of the urothelial markers of biomarkers. My passion has always been what we call oncobiome, which is use of bacteria in therapeutics for bladder cancer. Have been working in that for a couple of years. So, and being able to, I think the most important thing is being able to sit at multiple tables. So being able to sit on the epidemiology table, on the bioinformatics and biostatistics table, and being able to sit in the translational work. Because, with all the pivots that you take in your life, you learn experience and you gain insight that you haven't known. Having a straight path a lot of times provides very little ability for people to understand outside of their box of thinking. And I think that's one of the things that I really value is I've had a lot of different experiences, and those experiences really help me not only with research projects, also communicate with people outside of my expertise, which is urology.
Yeah.
And Laura, this year you've joined the journal, joined European Urology as an associate editor. So that's great to have you on board. Many of our listeners and viewers, of course, not just read the journal, but submit to the journal. So we love getting a little bit of perspective from the associate editors about what is it you look for when Briganti sends you a paper for triage. What makes the grade to at least get sent out for review, or maybe more interesting, what gets a straight reject that we don't want to take up the time of our valuable reviewers. So if you had any insights into how you approach that when you're opening up your submissions, we'd love to hear.
Yeah, of course. I think the first thing I look at is the novelty of an idea. And that's if it hasn't been done yet and it's an interesting and clinically important idea. That's one of the first things I look at. The second thing is clear language and clear methodology. using a lot of complicated language or perhaps confusing language. It confuses not only the reviewers and the readers, but also everyone else around. So having a very clear language across the board in the whole manuscript. And you actually if you look at many of the most cited articles, whether it's Nature or European or JAMA, many of those articles are simple in their ability to just use simple language and present the context of their methodology and their discussion in simple and identifiable terms. So when I see a paper that uses a lot of methodological language or a lot of things that are outside the spectrum for our readers, it always takes me back a little bit, because while the idea might be great, I think if their interpretation of the results is too confusing, sometimes maybe the authors themselves need to look back and look at the paper through different sort of view and through different eyes.
So true. Joyce, do you agree with that? You do a lot of reviewing for not just European Urology, other journals. What is it that catches your eye?
Yeah, well, of course, the subject. I only tend to review articles in my field of expertise. And I mainly start with the materials, methods section. And I start from there. So it should be very clear how a study is executed and if the methodology is correct. And it should be readable. I'm not an English native speaker, so it should be, for me, also easy to read. Yeah. So Laura, do you have any advice for trainees and young urologists who want to start with research, but are not sure how to approach it? Do you have any tips and tricks?
I say you don't have to have a mentor within your immediate setting or your institution. My best mentors, including Sarah Sutka, I cold emailed out of the blue and said, I need a female mentor in urologic oncology. So find people that you connect with, who you think you would like to work with, who you have interests together, and just email them. Most of the people are ready to mentor and are very helpful. And if they say no, then probably not a good mentor to begin with anyway.
That's, I think, really helpful advice. Good one.
Yeah, it's a really good point, isn't it, Joyce? I'm sure we all remember our great people who've mentored me in life. They still mean a huge amount to me. I talk about them all the time. And I think it's a different lens when you get a bit older. I'm a bit older now, and I can see younger folk around me. And occasionally I'll get a message say, it was really enjoyable working with you, or I appreciate this, that, or the other. And I realize, yes. So I'm now having a role in influencing younger people. So it's a really, really important part of all of our developments, whichever end of the spectrum you're on. Look, Laura, the last question we wanted to ask you about was a bit about your personal background and Ukraine, because you are Ukrainian. You were born in Ukraine, moved to the US, I think, at a young age, and you came on GUcast 3 years ago, whenever the war started, February 2021, is that what it was?
Correct.
Just after the war started, because it was so dreadful, these terrible scenes we were seeing. The military scenes were terrible, but all the scenes of people being displaced and everything. And you and your colleagues got going, went there, had a big support effort, a relief effort, etc. And we had a very emotional GUcast, one of our biggest episodes that year, featuring some of the work that was going on. So can I ask you just to update us a bit, I suppose, on Ukraine from your situation and the relief efforts?
Thank you, Declan, for asking about that. Well, we have been to Ukraine on 5 different occasions doing multiple humanitarian needs. So the first 2 times after I talked to you were at the border during the refugee crisis during the first initial couple of months. And then the additional 3 times were in Ukraine. So twice it was for lower extremity amputees, working with companies to provide prosthetics to the soldiers or civilians who had below the knee amputations, using a lot of the new 3D technology and being able to print the prosthetics within 24 hours, which is a huge need in Ukraine now with the mines. And then the last trip, and actually we are going another time in May, it's great because it's actually along what we do, and that's reconstructive urology. And even though I'm not a reconstructive urologist, a lot of what we do in oncology has reconstructive capabilities, right? So we worked with 2 additional reconstructive surgeons from here at Case Western, and we're going back in May, and we focused on all kinds of combat trauma to the perineum and abdominal trauma, so multiple gunshot wounds, mine explosions, where you wouldn't believe the amount of damage that we saw. Most of these men were 20 to 24 years old, about 13 to 16 different surgeries on their belly. And imagine going back into that and trying to do an ileoureter or a Boari or a reimplant on a solitary kidney. And that's what we essentially did. Otherwise, the reconstructive urology in Ukraine is extremely underdeveloped, and they realize that. And they're very appreciative of us coming and not only doing the surgeries, but we made sure to include 1 or 2 of their surgeons at every surgery that we did so they can continue to learn. And that's how we're going back in May again, to continue to work with the surgeons there so they can continue to teach each other.
Good gosh. I've never even read of that. I mean, you read it, maybe I just don't read deeply enough, but some of these stories, they just don't penetrate as much nowadays. Maybe there's so much other stuff going on, but this is very, very harrowing and very important work. And look, congratulations on all of that. Let's hope that this is a situation that is going to come to an end sometime soon. But we'd love to have you back on the GUcast podcast, perhaps after that May trip, just to update us on what's going on there, Laura. But look, thanks very much. It was great to have you on to discuss that very interesting paper with Tom, and even better to have you on to have a chat about yourself and about your role at European Urology. You'll be at the EAU, I understand. So do please come and visit our associate editors. We'll all be hanging around the stand from time to time. We're running a course at the EAU, and Laura and team always love meeting with viewers, listeners and readers of the journal. We're always happy to have a chat. Thank you, Laura.
Thank you so much for having me. Thank you, Joyce. Thank you, Declan.
Thank you.
And for our final segment, we still call it Nikita's segment, don't we, Joyce? Because Nikita Bat started this segment for us when we launched the podcast last year. It's a segment where we look at what else is going on in the journal, and we invited Nikita as a senior trainee to give us an eye on what caught her eye in the journal each month. But now she's on maternity leave, so we have a lovely roster of enthusiastic senior trainees from around the place who are filling her boots. And this month it's really great to invite Dr. Fabian Stangl, who's a senior urology trainee. He's a urology fellow now, actually in Bern in Switzerland. Fabian, thanks very much for joining us and filling Nikita's boots.
Thank you so much for letting me join on the podcast, Joyce and Declan. It's wonderful to be here and listen and contribute.
Well, tell us a bit about yourself. So you're at the end of your training, I think.
Yeah, I just passed my board exams, and I'm a senior PhD student, and just finishing up my master's and an MHBA focused on AI. We've talked about it, or you talked about it a lot, and I'm doing a PhD in infectious diseases in urology. I am very underrepresented topic in urology.
Wow, sure.
So these are my main interests. I'm a fellow in robotic surgery, so I'm currently training prostatectomies, nephrectomies, all the good stuff.
Gee, that's a good one, Joyce. You had a great conversation with Gio and Annabelle earlier, but I suppose now we're beginning to see people actually doing formal higher degrees in stuff like AI. But we need people like this coming through urology, don't we?
For sure.
So you've had a look around the journal, and I think you've picked out a couple of papers to quickly mention, and we'll have links to these in the show notes as well. But tell us a little bit about what caught your eye.
To be fair, I would have chosen any paper on infectious diseases. So I chose Professor Baard's letter on the hyperpole and misrepresentation versus the scientific evidence in equipoise in prostate biopsy. So there's a disparity in the AUA and the EAU guidelines recommending the transperineal approach. And Professor Baard is discussing the current data set we have available at our hand. And he published a paper in the Journal of Urology, the PRO-PC trial, where they did a single center comparison between infectious complications between those two, and found that there is, if it's in trained hands, there is basically no difference. And DAU urges to use the transperineal approach. And I think he wrote a very interesting part about what's available and how these two big organizations with these big minds behind them, and I know many of them very well, and I'm associated with the SIU, and I'm in the YAO group for infectious diseases, so I'm a bit biased, but I think the Atlantic splits the guidelines and our scientific minds. But I think it's a very it's a discussion starter, and I think we should have this discussion, and we need more data on this topic. But I'm also strongly minded, but like in highly developed countries, and I think you agree, Declan, like in Australia or Europe or Northern America, we should progress and ditch the transrectal approach, move on to the transperineal. We don't need any antibiotics for it. It's good for antibiotic stewardship. It's good for the patients. We don't have any infectious complications. We have good tumor diagnostics. But I think it's a piece breeders should definitely get into, maybe look at the guidelines behind it, and maybe get into the current literature, especially the ones who do prostate cancer in the daily practice.
Yes, I think it's quite an analytical, critical paper. On this clash of guidelines, I think it intensifies the debate on what is the best approach to take biopsies. You have on one hand the AUA give you some flexibility to choose between transperineal or transrectal biopsies, and then you have the EAU guidelines who take a quite firm stand in transperineal biopsies. So do you have any ideas why do we see these differences in guidelines? Declan, do you have any comments on that?
Look, my sometimes cynical answer to that is I think the US guidelines are quite influenced by what's available in their healthcare system. So, for example, if you gave the same emphasis to the use of MRI as a triage tool prior to prostate biopsy in men suspected of prostate cancer, then they would be doing a lot more MRI. But because they have difficulty accessing it in many places across the US, not well funded, I think the guideline organizations are more reticent. But the EAU will just look at the data and say, well, look, there's an extremely strong argument for using MR in the early detection pathway. So I think that I see that a little bit. And transperineal biopsy is identical. It's the same thing. You know, they have huge barriers to doing it because urologists in the US do this in the office. It's quite a good money earner, I think, a revenue bringer in thing. But switching to transperineal is not straightforward for them and not well funded. So therefore, I think the guidelines are a little bit slow. I'm a bit cynical, but it's not a new comment for me to say. And I suppose, look, Fabian, we will see more because Jim Hu, as you know, has recently published his very nice randomized trial comparing transrectal and transperineal. This is a very good trial. It's published in European Urology. It just came online in the past few weeks, and we will absolutely be featuring that paper in the podcast in a few months' time, and probably have more detailed discussion on GUcast before we get to that time. But yes, I agree with your messages, and wearing your infectious diseases hat, I don't think we talk enough about antibiotic stewardship, and that's a really compelling reason to do transperineal. And you have another paper as well, I think.
The second paper was by Professor Shariat's group, and they did a meta-analysis on the efficacy and safety of MDT, metastasis-directed therapy in prostate cancer. And since I'm doing prostate cancer in my daily practice, that's something I'm confronted with all the time, and it's just incredible to see what's going on in the space. But I think it's still kind of a void. So what should we do with these patients? And they analyzed and said, okay, it is a promising concept. It's something we should look into, but we still miss especially data on the overall survival. We know we can benefit with PFS, but we need to objectify our views and to get some RCTs to really have good supporting data and to shape the guidelines around it. But I think it's such an incredibly dynamic field, especially prostate cancer, and the difference of ADT, I think for all of us, and especially listening to your GUcast, Petting the Shark, and the effects of ADT, I think that's something we often underestimate. I think we really have to have the social intelligence to understand what's going on in our patients, and sometimes treating a patient and treating his cancer is good, but the side effects we cause are worsening the patient's overall condition, mental health, and so on. So I think it's good to move into other concepts, dive into it, especially in the oligo-recurrent HSPC. But another paper people should read, and I dove into it, and there's a whole bubble bursting when you really try to inform yourselves, and just the literature is overwhelming at the moment, and also the trials ongoing.
Yeah, I totally agree.
Really paper. Yeah, and what you said, I would invite our listeners to also go back to the podcast, the Geocast with Tim Baker. It was really impressive. And I'm sure, Declan, you remember that podcast with Tim Baker.
Yeah, thanks both for mentioning it. We'll put a link in the show notes. So Tim's an Australian journalist who was diagnosed with metastatic prostate cancer in his late 40s and was put on ADT. This is 7 or 8 years ago. He's a very good writer, a great storyteller, but he's written this book really about his experience on ADT. He doesn't criticize it because it's he recognizes it's been a very important part of his oncology management, but he's very, very critical about the way we manage side effects. So it's very sobering to read his book. It's called Patting the Shark, but we've done 2 podcasts with him about the topic. We did an original one about a year or 2 ago, and then we revisited it a few months ago. And it's a really good listen. But as somebody who prescribes a lot of ADT, and every urologist prescribes it to some extent, but those of us doing a lot of prostate cancer certainly do, I think this is essential listening so we better understand the impact, especially on younger patients, and also the strategies. We talk in the second podcast all about strategies to mitigate these side effects. So, yeah, great. But I think, the MDT discussion is very interesting, isn't it? Because the idea of, okay, this patient probably is going to need ADT at some stage, but maybe if we can defer it for a while, that's a good thing. I don't think we fool ourselves by saying metastasis-directed therapy really cures any substantial number of patients, and this is sort of what the meta-analysis is telling us. But if it defers ADT, I think is what you're saying, Fabian, that's a good endpoint. I believe it's a good endpoint. So, yeah. Well, look, great. Thanks so much for joining us. And you're very enthusiastic about podcasts, so we're very grateful to you for giving your enthusiasm to join and educate our audience today. We will be continuing with this segment for another few months while Nikita's away, and we have a few more people lined up. We may still have room for 1 or 2 more, depending on when Nikita comes back. So if you want to join and do something like Fabian did, just send us an email, platinum@europeanurology.com. Thank you very much. So that's all we have time for on this, the February 2024 edition of the European Urology Podcast. Thank you very much for listening. Please do subscribe. Please do leave us a rating. And please do get in touch with your suggestions for what we should feature on this podcast. We'll be back next month with the March edition. Thank you very much.